This is kind of either to wake you up or induce seizures, but what I'm going to try and do in a very short time is give you an overview of some of the thought processes that I've had and changes in what we've been doing. Still, the big controversy is in terms of what we do with congenital monocytic nevi is the surgery for reducing risk of malignant change, or is it related to appearance? And I don't know that we'll ever know what the exact risk is, but as a managing physician, it's necessary to have a philosophy and understand the pertinent studies. And these are only going to come about through long-term follow-up of a large group of patients, and treatment choices need to take into account both issues of medical concern and aesthetic concern. And the question is, can we carry out the excision to reduce the risk as much as possible, even if it's small, as well as optimizing the functional aesthetic outcome? And taking into account what we know about the fact that the risk is probably lower than it used to be thought to be, surgery still has to be designed so as to remove as much nevus as possible while minimizing scars in every means possible, as early as possible. But we also have to recognize that, you know, a scar may be accepted better than a nevus, but a bad scar is still a bad scar. So every effort should be made as we try and educate the public and have people be tolerant of people who are different, but the best chance of acceptance long term is to what closest approximates normal. The rationale for early excision is certainly the risk may be highest in the earliest years, but the excellent elasticity and superior healing of the tissues early on, excellent patient tolerance, getting much of this done before they ever really recognize it. But we've also seen that these techniques work well in the older patients. No single technique works in all cases, but in each body area, one or another happens to work better. What I'm going to try and show you as I start from the head down is really some of the thought processes and how things have changed in terms of how I've gone about treating these patients. And as a surgeon, it's necessary to understand all the reconstructive options and associated complications. Patient selection is critical. Recognizing how small a percentage of patients this group represents, it's very hard to put a large population of these patients together and be able to follow them over their lifetime. Each patient needs to be evaluated to the size of the nevus, normal tissue available, patient's tolerance, parents' tolerance in terms of their understanding of the process and their participation in the expansion. In similar cases, must be evaluated for effectiveness. Surgery isn't for every patient, nor is surgery a large nevi for every surgeon. We need to replace skin with and subcutaneous fat beneath, so the best means of doing that is using tissue expansion. Over a lot of years, we increased the number of patients. The large percentage of my tissue expander patients are nevus, and approximately 40% in the head and neck. This is very much of a team effort. I couldn't do this without my nurses, and the whole use of the internet and digital images allows us to follow these patients with them being expanded even outside the country. Reduces their time away. So starting at the head, I'll work down very quickly. A few important points in each area. The expanders can be placed safely at 6 months of age. Tissue expansion is the primary modality for the head and face. Can be repeated as needed, so serial expansion, but as we understand better the design of the flaps, the number of procedures can be reduced significantly. You do get some molding of the head in young children, but in fact it rapidly returns to a normal shape, and you may see more bony changes in the older kids than you do in the young kids. Combining the scalp and forehead together often allows you to reduce the number of procedures, and certainly occasionally we have a request to just do the forehead and leave the scalp. It's actually easier to do the two together. And how we design the flaps and understanding the use of transposition flaps, and what's different about a transposition flap, if it's expanded, you get both a transposition with a lot of movement and you get an advancement of the expanded base. But it's important not to overdo what you do, but here just a sequence of procedures, initial expanders, starting at 6 months. Then the second set of expanders, we can get the hair direction normal, we can put the scars at the borders of the aesthetic subunits, and complete the reconstruction quite early. But this works just as well in the older patients. She never seemed to not have a smile on her face, but it's important not to overshoot in what we do, so coming back to re-expand and making the patient understand it may be a couple of procedures to get there. In the end, we can minimize the visibility of the scars. Even in those cases with very limited amount of tissue, as we come to better understand how the tissue moves, we can carry out the excision reconstruction early and complete the reconstruction before it ever gets to be an issue for them. In the past, we first started with a medially based flap rotating up into the face for the cheek, but at the same time, in terms of the shape of the cheek and the movement of the tissue, it's much easier to do it laterally based than medially based. So while this worked quite well in this patient, today we tend to work with the flap moving the opposite direction. It's important, again, to not overshoot in what we do, come back and do the reconstruction in a second round of expanders. Here's the more typical movement of the tissue where it's released and brought up. The further we can get the expander under the neck towards the midline, the higher the tissue goes, or more easily the tissue goes. When we get down into the nasal area and limited forehead tissue, realizing that as you move the tissue across the forehead, you create a relative dog ear. You can move that tissue down into the nasal area to carry out the reconstruction. Getting the tissue in place, then sculpting it here. We were still using a single graft for the periorbital area, leaving just the lid margin. But often that has kind of a very flattened appearance, which is not that ideal. And now recognizing what we can do with the blood supply of the flaps, we can take a flap retrograde off of the expanded forehead flap to fill the area between the lid crease and the brow, giving a much more natural contour to the area than a skin graft, and then skin graft the lids if we need to. That makes the whole process a much more easier, more aesthetic reconstruction. This ability to take that extra tissue and move it down to the nose allows us to expand the forehead for nasal reconstruction while placing the donor site along the brow rather than in the central forehead. And although it's been said that isn't a big deal, it is in kids, I think, and if we can do it this way, it's a much better approach. Not all the flaps work. We happen to lose this central part of this flap. I grafted it, came back, actually elevated the graft, and put the dermal fat graft under for shape. At 3 years of age, we can get most of this done and then come back for others. The ear has to be staged as well, recognizing the aesthetic subunits as well as the structure of the ear, and we can do part of this early on, but the helical rim grafting needs to wait until they're 5 or 6 years of age. On the trunk, what we can do is very much dependent if we're dealing with a male or a female. We obviously have to stay away from the breast area and the female. A male, we can use that tissue and then come back later and place the nipples or nipple in the right position. Here we combined this with a free flap to the arm, waited till we were done with the trunk, and then took that single nipple share to make grafts and to place them in the right position later. Transposition flap is really the key to moving tissue on the trunk as well as up around the neck. This is something carried out right from the beginning. It places the scar in a better position, makes up the extra tissue so that in terms of growth long term, there's no restraint of growth or asymmetric growth and affecting the spine. Here's a typical sequence of procedures in just a couple. It's understanding where best to put them. Expansion is typically done over an 11 to 12 week period with 4-month interval between expansions. But even in situations where we think there's very little tissue to move, even if we have to move asymmetrically across the trunk in this young female in order to avoid any distortion of the breast area, that can still be done. Come back to get the last bit of nevus at the breast area when she's developed later. This was the first patient that actually did transposition flaps in our typical design on the trunk. This carries the tissue much further down. Again, the importance of being able to follow the patients long term, and even in later years, she could use some rounding out maybe in the buttock area, but we've not needed to do anything else. Going up the opposite way over the shoulders can be more difficult in terms of the variability of blood supply even expanded, but with repeated work, it's possible to gradually move this tissue up onto the shoulders and do it in such a way that functionally there's no disturbance and the scars can still be placed in very acceptable positions. Full thickness graft, really, other than just to the lids, probably at best uses on the dorsum of the hand. It most closely approximate the normal, and this is an expanded full thickness graft. The problem in other parts of the body is just the contour deformity because you're missing the underlying subcutaneous fat. So using the old pedicle flap off the trunk, we use the same principle for expanding for the arm, attaching the arm for 3 weeks, then separating it and following the patient's out. You can see she's a prominent dancer, arms in a very prominent position. And once more, again, even when we're coming up onto the shoulder, a little more complicated situation here. The idea is to complete the reconstruction and have an arm which can be readily visible with normal contour, normal function, and normal mobility. Occasionally, if we run out of tissue, a free flap as part of the process certainly works well. On the hand, really out on the fingers, the best thing is a staged excision, gradually thinning the tissue rather than grafting out onto the fingers. It gives a much more natural shape. On the lower extremities, it's more difficult to move the tissue. It moves well around the circumference, but not in an axial direction. Upper trunk or upper thigh, you can bring tissue down from the abdomen, but a free flap in that area, putting it in place and then gradually expanding and moving it around the extremity gives you the best contour. And then occasionally in the young kids, we're able to go ahead and use the same principles we do on the trunk, expanding the buttock area, wrapping the flap around the leg, so it's pedicled for 3 weeks, separating it, and just seeing long term how closely that approximates normal. Full thickness skin graft on the foot is quite durable. So our critical challenge is to do what we can to reduce the risk, however small it may be, while getting this functional aesthetic outcome, addressing issues of malignant degeneration, function, the aesthetic outcome. Excision with expansion is certainly the major process. Continuing to look at these patients long term, a lot of them are following out well into their 20s or 30s. Critical assessment of the results, and recognizing that in order to optimize the patient's ability to be within the normal, what's used as normal certainly has long-term benefits. And this is the kind of thing for any young surgeon, there's a whole life to work on ahead of time. Thank you.
So I have to say, as a radiologist, somebody who's focused on looking inside the body, to see that kind of work that's amazing. That is just amazing. So continuing in that vein, from Pittsburgh we have Dr. Deborah Becker. Her talk is entitled Making the Expansion Work.
When Dr. Newman first published his report of using tissue expansion, he cited as inspiration lip stretching, and on the left of the screen you can see a Mercy woman with a lip plate in, and he also cited the so-called long-necked women of Burma. What's fascinating about the fact that he used this as inspiration is that the neck coils of the Padang women don't actually elongate the neck. Rather, what they do is deform the clavicle and deform the rib cage so that there is an illusion of a long neck. And so actually it's not an expansion at all, it's actually a deflation. This was his series. He reported placing a rubber balloon under the skin and expanding it to reconstruct the ear, and this was in 1957. It wasn't the first time that expansion had been thought of, but just to give some historical context for the younger people in the audience, in 1957, penicillin had only been mass-produced for about 13 years and was being used primarily for other purposes, and cefazolin was a decade away from being patented. It's really amazing that he got the results that he got. When we talk about expansion, it is helpful to go over physiology. I know this is review for a lot of people, but it really helps to inform why we expand the way that we do. What happens? The dermis becomes decreased in thickness. This thinning of the dermis is important because overexpansion too quickly can lead to striae. There are increased fibroblasts and myofibroblasts, thickened bundles of collagen, a net increase in dermal collagen. And the capsular thickness is proportional to the expander pressure. When expanders are placed under muscle, there are ultrastructural changes to the muscle. The muscle fibers become disorganized, the Z-bands become distorted, and there's glycogen pooling within the muscle. Despite this, during expansion and after expansion, muscle still functions. But perhaps the most interesting change that occurs physiologically during expansion is to the vasculature. There's an increase in vessel number adjacent to the capsule, an increase in capillary caliber. There is a stretch mechanism that results in vessel growth that is proportional to mechanical force. And the ischemia and the hypoxia stimulates angiogenesis. And the alert resident in the audience will immediately recognize all of this as a delay phenomenon. These were Barian studies of a random patterned skin flap versus an expanded skin flap. And you can see how there is just increased vascularity in B. So how do we get from here to there? How do we make the expansion work? And it starts with choosing an expander. Well, how do we choose an expander? You sort of open up a catalog, see a bunch of choices, and sort of say, okay, this sort of seems like it will be good. Well, what I'd like to do today is to propose using geometric calculations as the basis for starting the decision-making process of choosing an expander. And what's nice about this, what I like about it is they are accessible, sort of back of the envelope calculations. Let's start with the spherical expander. All expanders can be defined by width, depth, and height. And Praveen Patel published his poor man's recipe that I've sort of adapted. So we will start with equation 1. The convex area of the sphere is defined by pi times r squared plus h squared. And the volume is defined in equation 2. Now, we can't stop there because keep in mind that once we expand, we are concerned about the area gain of skin rather than just the expander itself. We need to not only cover the defect, we need to also cover the area in which the expander was placed, and we need to cover any tissue that is lost during rotation. So formula 3 is actually a constraint on the area of the expander. And if we rearrange these equations, we get number 4, which will help define the volume that we need for a given radius in a given area of a defect. Now, a useful guide, and this is the back of the envelope calculation, is what sort of height do you need in an expander? And a lot of people have argued that calculating the height is very difficult and complex, which I will concede that it is. What's nice about this is that it is a quick and easy way. The height is equal to the square root of the area of the defect divided by pi. And so the height approximately needs to be 0.6 times the square root of the area of the defect. 0.6 is 1 divided by pi. Everybody with me so far? Let's go through an example together. Let's say we have a defect that is 60 centimeters squared. Okay, so we calculate out what sort of height of a spherical expander do we need. Okay, we calculate it in. It is 4.6 centimeters. And let's say that we go back to our catalog, and there are 2 expanders. One's 6 centimeters and one's 8 centimeters. Well, which one do we choose? And how do we know the best one to choose? And here's where the formula comes in handy. If we choose the 6 centimeter diameter expander, you can go through the calculations, and we will need a volume of 105 cc's to get the area gain that we need to cover the defect. If we go with the 8 centimeter diameter, we actually need 154 cc's. So you can see it makes more sense to choose the smaller expander because you need less of volume to get adequate coverage.